Okay, now the last talk in this session on quality of life will be provided by Dr. Ayse Kuspinar, who is an assistant professor at the School of Rehabilitation Science at McMaster University, who's also a physiotherapist with clinical experience, as is Dr. Vanina del Bello-Haas, who is also a physiotherapist with clinical experience and an associate professor in the School of Rehabilitation Science at McMaster University. And we're very fortunate to have them here to present Enhancing PALS Voices, Preference-Based Measures on Health-Related Quality of Life. Thank you so much for being here, and please, anytime you're ready.
Thank you, David.
Yes, thank you, David. We're happy to be here. So this is Vanina, and I'm going to start. We have some objectives here for you for our presentation. So what we would like to do in the next 15 minutes or so is to describe the main goal of a patient healthcare system, talk about quality of life and health-related quality of life and describe some of the differences, provide a brief overview of some of the research that has been conducted related to quality of life in patients with ALS, describe the purpose of a health-related quality of life measure, which will be the most amount of time we'll spend on in our presentation, differentiate between a health profile measure and a preference-based measure, and provide you with some examples, and then outline some of the main phases of a research project that we will be undertaking to develop a preference-based quality of life measure for people with ALS. So when we think of a patient-centered healthcare system, the main goal of this type of system is really to enhance patients' health and quality of life. Typically, healthcare systems are more concerned with outcomes such as morbidity or mortality, but it really is critical to incorporate the patient's voice and perspective in undertaking evaluations of therapies. And by therapies, we mean drug treatment or other types of treatment, such as rehabilitation treatment. So a more structured approach of including patients' perspectives in the evaluation of various treatments that really encompasses what's happening with the patient in terms of impairments, activity limitations, and participation restrictions that the disease influences and that treatment influences emerged in the late 1980s. And the construct that came forward in the late 1980s was something called health-related quality of life. All right, so what do we mean by quality of life? The World Health Organization defines quality of life as an individual's perception of their position in life, and it relates to the context of the culture and the value systems in which they live and the relationship to their goals, expectations, standards, and concerns. So quality of life is really broadly defined by health-related factors such as psychological state, level of independence, social relationship, personal beliefs, and the relationship of the individual's characteristics to the environment. But it's also determined by non-health related factors such as someone's job, family, friends, spirituality, and other life circumstances. So really, quality of life reflects the view of a person, and it's the person's perception of what quality of life actually means to them. So we may have two individuals with the exact same health state, the exact same condition, but those two individuals may not and often will not have the same perceived quality of life. So why do we want to look at quality of life? Well, certainly we can look at quality of life to assess the perceived value of a new drug treatment, or we can look at quality of life to assess the perceived value of the aspects of clinical care. So quality of life in people with serious medical conditions such as ALS is very often underestimated by others. And by others, I mean healthy individuals, caregivers, and healthcare professionals. So I've just included some of the research that shows that caregivers, healthy persons, next of kin, tend to view aspects of a person with ALS's life very different in terms of quality of life. So for example, caregivers often rate patients as having less energy and more suffering. Healthy persons and caregivers estimate depression to be present more frequently. They tend to rate general and psychological well-being lower than someone with ALS. So what this is reflecting is that quality of life is very personal and really cannot be determined by someone other than the person who is being asked about quality of life. So some of the research related to ALS has defined some of the factors that actually impact quality of life in people with ALS. On the negative impact, things like depression or hopelessness or anxiety, dysphagia, fatigue, pain, and pseudobulbar affect have been found to negatively affect quality of life for PALS. On the positive side, having support, believing in something religious or having spirituality, being involved in a multidisciplinary clinic, having access to an assistive device for communication, having strong coping strategies, being offered non-invasive ventilation and gastrostomy positively impact quality of life for PALS. I'm going to turn it over to Ayse.
Thanks, Vanina. So health-related quality of life is often interchangeably used with quality of life, but it actually has a very different and distinct meaning. Health-related quality of life refers specifically to the aspects of quality of life that are affected by health, which include physical, mental, and social well-being. So health-related quality of life measures can be used in a variety of settings and for a variety of purposes. They can help us capture aspects of health that can't be measured with a test or a device, but that can only be measured from the patient's perspective. They can help us better understand how ALS may affect a person's health and well-being, and identify areas that need to be targeted during treatment. They can be used in clinical trials to evaluate the impact of a treatment from the patient's perspective, whether the treatment be medication or rehabilitation such as physiotherapy or occupational therapy. And last but not least, they can also help us compare the costs and benefits of different healthcare interventions in ALS and help us answer questions like, does this treatment work? If it works, at what cost? And how does it compare with alternative treatments? So health-related quality of life measures generally fall into two groups based on how they are constructed and scored: health profiles and preference-based measures. And we'll look at these more carefully in the next upcoming slide. So a health profile includes multiple questions and can be generic or condition-specific. On the left side of the slide is the RAND 36, which is one of the most commonly used generic health profiles in clinical trials for ALS. It has 36 questions that describe different aspects of health, such as physical functioning, social functioning, and mental well-being. So here is an example of a question from the RAND 36 on physical function. The following items are about activities you might do during a typical day. Does your health now limit you in these activities? If so, how much? And the activities may be vigorous activities, such as running or lifting heavy objects, moderate activities, such as moving a table or pushing a vacuum cleaner. And the response options are for the RAND 36 for this question is yes, limited a lot, yes, limited a little, or no, not limited a lot at all. So health profiles can also be ALS or condition specific. The ALS specific quality of life instrument is a commonly used health profile in ALS. This instrument has 50 questions on different aspects of health that may be affected or affected in ALS. So here's an example of some questions from this scale. Please rate the following symptoms and experiences according to how much of a problem each one has been for you. Please respond about how you felt or what you have experienced over the past week using the scale provided. So for example, pain. And the response options for this are from 0 to 10, a 10-point scale, 0 being no problem and 10 being tremendous problem. And The ALS-specific quality of life instrument includes items that are more specific to ALS, such as eating, mucus in my throat, speaking, sleeping, bowel and bladder. So health profiles are scored by domain or subscale. The RAND 36, for example, produces 8 domains: physical functioning, role limitations due to physical problems, role limitations due to emotional problems, bodily pain, vitality, social functioning, mental health, and general health. And each of these domains are scored from 0 to 100, where higher scores indicate better functioning. We can't combine these domains to form an overall score or single score of health-related quality of life, which makes it a challenge when we want to evaluate the effectiveness of interventions or treatments. For example, if a treatment has a positive effect on physical health, but a negative one on mental health, it's impossible to determine whether the treatment led to a net improvement or decline in one's health-related quality of life. So preference-based measures, on the other hand, do provide a single index or score for health-related quality of life. This is because in the development phase of these measures, patients or members of the general public are asked to rate their preferences for each of the items or questions in the measure. So this is a visual analog scale on the screen that goes from 0 to 100, where 0 is the worst imaginable health state and 100 is the best imaginable health state. Patients are given a set of items or health states and are asked to place each one on this line so that the distance between the items indicate the strength of a person's or individual's preference for the item compared to another. So this is an example from stroke. Patients with stroke said that not being able to participate in sports was better than not being able to walk, but not being able to walk was better than not being able to speak. So having a speech impairment had the biggest hit on the health of patients with stroke, resulting in a net decrement from full health by 70 points. And like health profiles, so preference-based measures are in the format of a questionnaire. The most commonly used preference-based measure in ALS is the EQ-5D. It's multidimensional and so measures different aspects of health. And a key feature of all of this measure and others is that they are relatively short and include one item per domain. So as we can see here, the EQ-5D includes one item that represents mobility, one for self-care, one for usual activities, pain, and anxiety or depression. Commonly used preference-based measures in ALS are generic. So this means that they include a common set of domains that most people will value highly, but exclude any additional domains that are specific to a condition. And studies have shown that generic preference-based measures in ALS do not adequately reflect the disabilities and health concerns of people with ALS, and lack sensitivity to change when evaluating treatments. So we would like to develop a preference-based measure for people with ALS. Such a measure could be used to evaluate the impact of ALS on one's health and functioning. It can be used in clinical trials to evaluate the effectiveness of different interventions or treatments, whether it be drug therapy or rehabilitative approaches, and determine the cost effectiveness of different treatments in ALS. So development of the measure will involve several steps or phases. We will first identify the domains that are most important to the quality of life of people with ALS, and that should be included in the measure. We will then develop the items with researchers, clinicians, and people with ALS. Once we have the items developed for the preference-based ALS index, we will translate them into French. And following this, we will then ask people with ALS to rate their preferences for these items, which will help us develop a scoring function for the index. And finally, we will evaluate the validity of or the performance of the preference-based ALS index by comparing it to other measures of health-related quality of life. And all of the steps can be done remotely using online surveys, telephone, Skype, or Zoom. And we'll be looking for people with ALS from all over Canada to participate in our project. So stay tuned for recruitment. Thank you.
Thank you.
Thank you both. That's a really amazing project. We're very excited about it coming to fruition, and had a couple quick questions. So the idea behind this would be hopefully that it could be incorporated into all of the assessments in clinical trials that happen here in Canada, because I'm assuming because the answers will be preference-based, based on Canadian individuals. And then, so if say there was an industry trial that had 6 sites in Canada, it would be helpful in, say, a phase 3 to have this alongside an ALS FRS and other measures to be able to explain what the value of the study is, you know, for potential reimbursement and other things. Is that sort of what it's?
Yes, that's exactly what it is, Dave. It's essentially, it will really help us to evaluate a treatment, and the treatment, it can include a wide variety of treatments from the person's perspective with ALS. So it can tell us what are the positive and negative effects of it and the overall impact on one's health-related quality of life. And the advantage of preference-based measures as opposed to health profiles is that it gives you that single value from 0 to 1, an index or a single score for health-related quality of life. And that's really important when you want to evaluate the cost utility or cost effectiveness of treatments. So you can link that value with quality adjusted life years and look at the cost utility of different treatments in ALS.
It's yeah, and it's also very timely because with there may be a number of people who are listening today who contributed to what the value of a recently approved drug by Health Canada was to their quality of life and the idea of what it would mean to them. And so I guess what this does is formalize a measure even before the stage of potentially, like alongside understanding whether a potential therapy works or not. So
yeah, absolutely. It would be an outcome that could be used to determine the value of the intervention or the therapy or the treatment.
Really, really great as more therapies come along in the field to have something like this that's really going to show, you know, the uniqueness of ALS to those who, you know, stand to reimburse and help to get drugs in the hands of people as they become developed. So thank you very, very much for joining us today, and we're very excited to watch the progress of the study.
Thank you.
Thank you both.